Okay, why don't we get started? Again, my name is Dr. James Greenblatt, and we're going to be talking this evening on inflammation and a neuropsychiatric illness, what it means, and how to treat it. And we're really going to focus primarily on depression because there's the most literature, and I believe the biggest gap between what the research has clearly demonstrated and our clinical practice. There'll be plenty of time for questions at the end, and I apologize. I have a lot of slides. There are slides I'm going to go through very quickly, and then there are slides I'm going to spend more time on so you can get the gist of what we're trying to help understand, which is the process of inflammation and neuropsychiatric illness. So in focusing on depression, it is serious and it is life-threatening, and the numbers are increasing and staggering. The concern, obviously, is the disability, and there is research now showing that depression is going to be the second leading cause of disability worldwide within the next 10 years. That's second cause of disability worldwide. The crisis is significant for our children, and suicide is the third leading cause of death, and more kids are dying from suicide than all the attached chronic illnesses that you see in front of you: AIDS, stroke, lung disease, etc. Our culture is looking for the magic pill, and as a psychiatrist, I can be the first to tell you that my profession has tried to help. We're all looking to feel better. The pharmaceutical industry has taken complete control of psychiatry and really has, in certainly the treatment of depression, kind of missed the underlying cause. And the work that we do in integrative psychiatry is looking at the underlying cause of depression or any major psychiatric illness. Depression is not a Prozac deficiency, and it is sometimes hard for my colleagues to appreciate that as more and more medications get prescribed without clear rationale. When we talk about depression, all these research studies on medications looked at very modest changes, and one of the major studies that were done for the treatment of depression, a study that wasn't funded by the pharmaceutical companies, demonstrated that almost 2/3 of patients continue to have residual symptoms, meaning after they were considered treated for the depression, they still suffered. They still suffered with symptoms that were not helped by the antidepressants. And, you know, we've all been on this misguided, really deceptive course by the pharmaceutical companies where up until recently, the academic community thought that 94% of all the antidepressant trials were positive, but what the pharmaceutical companies did, they didn't publish the studies that were negative. And so over the last couple of years, research has come out that these trials, if they were integrated with all the other research trials, that half the studies would fail to show a benefit better than placebo. And that's really the starting point when we want to talk about understanding depression as a disorder of inflammation. Understanding different ways of treating depression is the basic fact that for minor to moderate depression, the response of these medications is comparable to placebo. The placebo response in depression is 30 to 45%, and the antidepressant response has been shown to be comparable. I mean, that is both frightening and concerning, particularly as our patients continue to struggle. So all these books have come out complaining the field of psychiatry. Many of us have part in our concern with medications, But I guess part of the work that we're trying to do in integrative psychiatry is it really stop complaining and try to find solutions. And the solutions that we will talk about tonight is certainly another concept of how we might understand depression. The solutions, my colleagues, some are helpful, some are not. For people that don't respond to medications, we can use more medications, antipsychotic medications. There's ECT, there's vagal nerve stimulation, the VNS, TMS, and reference EEG are two things that we use because they're safe and effective. Transcranial magnetic stimulation is TMS, and you can get more information on our website. And reference EEG, I'll talk about it in a minute. But my colleagues have reverted to surgery, and for those people that don't respond to antidepressants, psychosurgery is now not uncommon, and we've all heard of the prefrontal lobotomy from One Flew Over the Cuckoo's Nest. The concerning piece is that Dr. Moniz, who discovered this procedure, actually won the Nobel Prize, and he was also shot and killed by one of his patients. The brochure at one of the universities, I think it was Brown, we don't like to call it psychosurgery anymore, it's neurosurgery. So that's my concern. The reference EEG is something that I've been involved with for 7 years. It is an alternative at looking at a QEEG that helps us predict which medications might be helpful. It doesn't look at whether someone has an illness or not. It looks at a brain function, and it defines a medication regimen based on a database that's been collected over years. So there are some tools for medication, but our current paradigm of using medications is limited and really no better than placebo for mild to moderate depression. Genetics clearly have been shown to be critical in mood disorders and depression, but I think the most important part when we talk about genetics, what has been clear in the literature that we haven't found a gene for depression, and the more research we do, what we find is that the risk for depression is most likely triggered by environmental factors. So there's a genetic vulnerability, but something is happening in the environment to trigger that vulnerability. And that's where nutritional deficiencies and stress and the concept of epigenesis comes in. So epigenetics is looking at how the genes are not changed, but the expression of certain genes are changed. And so this tremendous genetic liability for depression is real, but it doesn't mean everyone will develop depression if they have a family history. And the trigger that I want to talk to you about this evening is this concept of chronic inflammation. So we recently came out with our book on depression, and I use a mnemonic, the zebra approach, and I chose zebras because each zebra stripe patterns are unique. And when we look at underlying causes of depression, everybody's different. And the zebra mnemonic just goes through some of the nutritional deficiencies as well as some of the environmental factors that contribute to depression. But if we look at this list, take care of yourself, T talks about sleep deprivation and stress and diet, exclude is food allergies and neuropeptides, casomorphin, gliadorphin. When we look through this book, one of the summarizing concepts is that we're really talking about this concept of inflammation, the brain on fire has been a description that really brings to home the concept that I want to share with you this evening. The brain on fire, what does that mean? Well, it's really hard for some of us to appreciate because we might not understand what that's like. But when we look at inflammation, when we look at chronic inflammatory disorders, we understand what rheumatoid arthritis both feels like and looks like. We know what asthma is, and we know what multiple sclerosis is. These are disorders of inflammation. And in some ways, it is easier to pick up when the joint is swollen or the lungs are inflamed than it is for the brain being inflamed. But these are chronic inflammatory disorders, and it's the same model that we're going to use to talk about depression. So when our medical information gets to Newsweek in Time, then we know it's okay to talk about it. So this was a number of years ago, but it talks about inflammation being linked to all of our major chronic illnesses. And what has been clear in the psychiatric and medical literature is the same processes of inflammation is related to neuropsychiatric illnesses. And that's depression, OCD, schizophrenia, Alzheimer's, ADHD. Inflammation in the joint, inflammation in the pharynx, a sore throat, or a swollen finger are visual images I need you to have in the back of your head as we talk about inflammation in the brain. So I remember a number of years ago being sick with the flu, and I just felt miserable, and I just had a chuckle to myself some time during the course of that day, because it just hit me for the first time what serious depression feels like. And we call this sickness behavior. We have all felt miserable due to a viral infection. And this sickness behavior is an immunological model for depression. It is a nonspecific reaction to infection. And what are the symptoms? When you're home with the flu at its peak, you're feeling horrible, lethargy, malaise, you're not concentrating, your appetite goes down, you have no interest in pleasurable things, you're weak. Those are depression-like symptoms. And what we've discovered over many years, this is not new research, that sickness behavior is mediated by chemicals called cytokines. And that's the word for those non-scientists in the audience that I need you to remember. And that's what we're going to be talking a lot about, is this chemical class of from the immune system called cytokines. And there are lots of different cytokines with these long names and abbreviated numbers: IL-1, 6, TNF-alpha, and IFN-gamma. But you don't need to remember the numbers as much as you need to remember the word cytokines. And cytokines is how the immune system talks to itself and the rest of the body. It's the chemical messengers of the immune system. Just like neurotransmitters are the chemical messages of the nervous system, and hormones are the chemical messages of the endocrine system. But what we know is that these levels of these chemicals correlate with the levels of anxiety, depression, and cognitive impairment. Okay? The levels of these inflammatory chemicals correlate with the levels of these cognitive symptoms. So we have a link between this overactive immune system, these cytokines, and depression. So we know these prolonged pro-inflammatory cytokines contribute to depression. And they do it by a number of ways that we're going to talk about this evening. And these are a couple studies that were very well done a number of years ago and but really important to understand. So we looked at patients with depression, and they had higher levels of these inflammatory cytokines. And the cytokines, these immune chemicals that are what we call anti-inflammatory, were actually lower. And what was the most remarkable, I think, for the research community is that the antidepressant medications, they're here Zoloft, sertraline, decreased these inflammatory cytokines. So giving an antidepressant decreased these inflammatory cytokines in the body. So we actually understand the mechanism of how these cytokines affect depression. And it's simple, and it's really important that we understand it. So what happens is these cytokines activate an enzyme that we'll just abbreviate IDO. And this enzyme is critical for eliciting the symptoms of depression. Why? Because this enzyme breaks down serotonin as well as degrading tryptophan. Now, many of you have seen this slide or understand the concepts here, but just to review for a minute, to make the neurotransmitter serotonin, you need the amino acid tryptophan. To make the neurotransmitters dopamine and norepinephrine, the DA and NE, you need the amino acids L-phenylalanine that goes on to make L-tyrosine. So every medication that we use for depression, every psychotropic medication affects these neurotransmitters. Most of our antidepressants affect the increasing serotonin. We do studies on animals and humans looking at tryptophan, and what do we find? We find patients get irritable and depressed. So what we have is a simple model here that with chronic inflammation, these cytokines start producing an enzyme called IDO. And what does this enzyme do? It depletes serotonin. Okay, it reduces the levels of serotonin, which means it's going to affect one's mood. And then even more critically, it depletes tryptophan. It degrades tryptophan, and we're going to talk later about what it does to tryptophan that triggers further inflammation. But that's the model I keep coming back to, is inflammation, cytokine release, we're breaking down serotonin and tryptophan. A very simple model, and it is powerful as a inducer of depressed mood. So one of the studies that was simple and elegant, what about an anti-inflammatory agent? What about giving a small dose of aspirin? 160 milligrams of aspirin was given to patients who didn't respond to the antidepressants. In 4 weeks, the aspirin antidepressant combination showed a much higher response rate and a much higher remission rate. So we have an augmentation effect of the antidepressants by just adding a low dose of aspirin. Although it's very important that with the non-steroidals, this was another study, that when the NSAIDs were given, it actually did not enhance it. It impaired the anti-inflammatory cytokines that were produced from the antidepressant. So the NSAIDs in this research paper was actually shown to not help. So how do we know that this is important? That we've actually, for many years, been injecting cytokines into our patients who have chronic anti-inflammatory illnesses, like MS, arthritis, and hepatitis C. So one of the cytokines that we've been using for many years is interferon. And what happens if we give interferon, which is a cytokine, to our patients? Well, they get depressed and they get irritable and they have many, many psychiatric symptoms. We have patients that had interferon injections that got so depressed and agitated, they had to be admitted to our psychiatric hospital every time they received their injection. Okay? And we've been studying this for many, many years. If we inject interferon, we have differing psychological symptoms, from suicidal ideation apathy to decreased sexual function, and irritability is the most common cognitive defects and depression. So we inject these cytokines into our patients to treat hepatitis C and other illnesses, and it is a horrific mood-altering medication for a subset of patients. Some of the sides show 30 to 40%. Many individuals don't report the severity of the depression to their treating doctors, but it is now a screening test that's very important. Again, how does this cytokine, well, we use interferon. This is just a schematic of what we talked about earlier. It induces this enzyme where you break down tryptophan as well as breaking down serotonin. So why would our immune system, which is supposed to protect us and help us, cause depression? To me, it's a fascinating question, and the answer appears to be quite simple in one effect. Tryptophan is essential for the survival of many infectious agents. So our immune system, in this incredibly magical way, starts withdrawing tryptophan and sacrificing, if you will, our mood for a brief period of time as another way, perhaps, of fighting the infectious agent. So I just want to make sure everyone got that. I just shared with you there's lots of research to support that our immune system produces chemicals that cause depression. Why would that make sense? Well, during the course of evolution, by decreasing tryptophan, we were able to better fight the infectious microbes. Another theory as to what is going on talks about the microorganisms that were so ubiquitous when our ancestors and maybe even our grandparents were playing in the mud, not wearing shoes, and not taking antibiotics, and not sterilizing everything that we do and eat. So the amount of bacteria in our society, as well as in our GI tract, we'll talk about later, kind of modulated our immune system and kept it in check. And then the other theory that I mentioned again is that conserving energy by being somewhat tired, depressed, and lethargic might help the immune system fight the invading microorganisms. So it makes sense, but the summary is, if we look at inflammation as a physiological process activated in a diverse range of environmental factors we're going to talk about, but this diverse range is what we call depressogenic. Inflammation causes depression. And actually, Andrew Weil is just coming out with a book on depression, and the press release talks about he really is focusing on just this one aspect, looking at inflammation. So what are the sources of inflammation? For many, this is what you do for a living, trying to understand, and I just want to reframe these nutritional and environmental insults as agents of inflammation. So their diet, processed diet, environmental toxins, infections, allergies, dysbiosis, stress, nutritional deficiencies, and sleep deprivation. These are all sources of inflammation that contribute to depression. I'm going to talk about many of these. Each one of them obviously would be an hour seminar, but let's just try to look at a few. And we're going to start with probably the most significant is stress. And stress-induced elevation of the glucocorticoids, it stimulates the immune system. It stimulates the immune system that contributes to this state of chronic inflammation. And again, the mechanisms have been studied for years, and whether it's early stress and trauma or a current stress, we have a very, very powerful response from the brain that creates this cycle through hormones, primarily cortisol, that stimulates the immune system, and these cytokines get back into the brain to contribute to this state of inflammation. And for those scientists in the room, here's a more elaborate picture of how the peripheral response of our immune system causes the brain to be inflamed. And part of what I wanted to share with you this evening is this information has been written about and talked about for many years, and it is a very important part of what I would call academic research on depression. But for some reason, not really been integrated into the clinical of depression. Very few psychiatrists talk about inflammation. Very few clinicians look to inflammation as a kind of overarching theme that needs to get addressed before somebody is going to feel better. So after stress, I think chronic dysbiosis is probably the second most common of chronic inflammation. And there's research actually in the psychiatric literature talking about how, again, time decreased exposure to many sources of bacteria, from higher rates of C-sections to our antibiotic use, both in our food supply as well as with our children, that we're decreasing the protective immune modulating effect of what was referred to in one article as our old friends, the 3 or 4 pounds of bacteria that line our GI tract that helps our immune system stay in tune. When we talk about chronic inflammation, it's certainly easy to understand allergies as being a source of immune dysregulation and inflammation. And recent research has demonstrated that people with allergies have double the risk of depression. Why? Again, these pro-inflammatory cytokines are released by this chronic allergic reaction that contributes to depression and anxiety. There are different kinds of allergies. There's the IgE, immediate hypersensitivity reactions, that many of us are familiar with, and our kids with the nut-free tables. That causes chronic inflammation, but we're also worried about what we call IgG-DELAYED hypersensitivity reactions. And these are not immediate. There are many, many variable symptoms. But what's been clear from many testing for many years is these foods cause a vast array of psychological symptoms. They're not immediate, but they clearly contribute to the concept of inflammation. So we have two sources of allergies, at least IgE and IgG mediated. What about chronic infections? There are many infections now that are being looked at for both neuro and chronic psychiatric illness. There's this BORNA virus that has been clearly associated to be correlated with depressed mood in animals, and also recently found in humans. When the virus is treated, the symptoms of depression resolve. Again, a simple model for inflammatory infectious agent contributing to mood disorder. What has certainly gotten a lot more press and people are treating more is Lyme disease. Again, a chronic infection. But it's not just the virus, the bacteria, that is causing the depression. It is our body's cytokine inflammatory response that needs to get understood and needs to get treated aggressively. And clearly, everything, when we talk about chronic infections, whether it's H. pylori in the gut or chronic gum disease, also creates a state of chronic inflammation. The list goes on to chronic yeast infections. This I took from the 1984 article by Dr. Crook in JAMA, looking at mood disorders and chronic candida infections. One of the tests that I've been particularly interested recently is looking at a metabolite of Clostridia. Many of you have seen this on the organic acid test, but looking at inflammatory marker HPA found on the organic acid test. This is a metabolite of the amino acid tyrosine, but it is clear from the literature that this abnormal metabolite is inflammatory and stimulates the nervous system, and we've seen increased incidences of schizophrenia, OCD, and depression. This is two cases. This is an individual with chronic schizophrenia. As you see, the HPA marker is elevated. As that marker came down, symptoms improved. This is a boy who had OCD, treated with multiple medications for many, many years, sent around the country of multiple treatment programs. And this was the first test that we did. This was just treated with high-dose probiotics. As this HPA marker normalized, the OCD became dramatically improved, where this child was integrated into back to a normal school system. So we talked about chronic yeast infections, Clostridia infections, Lyme disease. The list goes on and on. Chronic infectious agents contributing to this inflammatory response that contributes to neuropsychiatric illness. What else is on our list? Well, sleep deprivation. We know it causes many problems. Here's just some of the research for the academics in the room, or for people who don't believe me. Good academic research. These were all done by one group. But let's look at one of these studies where modest sleep restriction. So if 7 to 9 hours is normal, being the average. So this was just 6 hours per night for 1 week, 25 healthy young adults. And after a week of that modest sleep restriction, we see elevations in these inflammatory cytokines, the IL-6 and the TNF-alpha. So here we have modest sleep deprivation causing elevation of these pro-inflammatory cytokines. Okay, so how do we measure inflammation? What do we do with this information? Well, we have some very markers done on all patients and should help us look for treatment modalities. So C-reactive protein is something that's routinely done by our medical colleagues. It's not routinely done by our psychiatry colleagues, but it needs to be, because it is a simple blood test that reflects chronic inflammation. Now, we can't always understand the source, being infectious, cancer, autoimmune disorders, but there is a high correlation that I'll talk to you with neuropsychiatric illnesses. So this is looking at C-reactive protein and memory in older adults. And here they looked at individuals with detectable elevations in CRP, and they had lower performance on memory tasks and recall and recognition. The brain scans of those with CRP indicated this presence of slower brain volumes. These are all, the next few studies I'm going to share with you, all came out in the past few months. Again, 873 non-demented elderly, markers of inflammation showed decreases in cognitive function. And again, another study, this was interesting because it was self-rated health. And they looked at both the C-reactive protein and another marker of inflammation. But what it showed is poor self-rated health associated with inflammatory markers. So these adults, they self-rated not feeling well, and those that had the higher elevations also demonstrated the higher inflammatory markers. So what do we do with this information? Well, our pharmaceutical companies again beat us to the punch because now we're looking at new indications for the statins. So particularly Crestor has been approved for elevations in C-reactive protein, looking again at lowering cardiac risk factors. But the research is quite clear. Elevations in CRP and other inflammatory markers elevates our risk for cognitive impairments as well as neuropsychiatric illness. So C-reactive protein is a simple blood should be done and can monitor inflammation. And then we have a much more specific marker of inflammation in the brain, and this is a compound called quinolinic acid. This is on the organic acid test from Great Plains, and this is a marker of brain inflammation. This marker by itself has been related to neuropsychiatric illnesses. This is a patient that we've been seeing who had, as you see, elevations in the quinolinic acid, a 50-year-old gentleman who started noticing cognitive decline, anxiety, and depression, did not have those symptoms a number of years ago. Quinolinic acid is what happens when we talked earlier about where this enzyme that degrades tryptophan, it causes the synthesis of the chemical quinolinic acid. And this acid, which is easily tested for, has been shown to be involved in all the neuropsychiatric illnesses you're looking at in front of you, from dementia to ALS to MS to Parkinson's, and we've seen it in anxiety, depression, and OCD. And there's research to support injecting quinolinic acid in the brain causes significant neurotoxicity. So this is kind of how I want to summarize this for you. Might be more information than you want, but bear with me for a minute because these are really simple concepts that need to get integrated into our treatment of depression. So we have some inflammatory process, and we produce these cytokines. And the cytokines produce this IDO, this enzyme that causes a deficiency of tryptophan and serotonin. And it also causes an increase in quinolinic acid. So the increase in quinolinic acid causes glutamate to be increased, and glutamate is a neurotoxin, and that causes neurotoxicity. The decreased tryptophan, we're going to make less serotonin, contribute to depression, irritability, mood swings. And we're going to degrade serotonin itself, which is going to cause those same symptoms, but we use serotonin to make melatonin with some of our trace minerals like zinc and some of the B vitamins. So as these inflammatory process continues, our ability to make melatonin decreases. So we get the sleep disturbance. This is from a wonderful article in the Archives of General Psychiatry looking at how inflammation contributes to depression. So these is traditional medicines and their charts as to factors associated with inflammatory markers. And many of these we've talked about, but stress, chronic medical illness, obesity, diet, nutritional deficiencies, sleep, social isolation, low socioeconomic females, and smoking all contribute to these peripheral inflammation markers. And the factors that they report, which we're going to kind of modify a little bit, are things like therapy, exercise, and antidepressants. Well, in our world, that's not enough. Depression clearly has been shown to respond to exercise. Exercise is anti-inflammatory and is probably the mechanism that helps depression. But in the world that I travel in treating depressed patients, I would get up early to go running, but my toes against me 10 to 1. It's not easy for someone struggling with depression to exercise. Clearly, our nutritional interventions can help with energy and help motivation, but exercise is tough. So I've kind of mended this chart a little bit, and we're going to talk about some of the things we can do. Certainly, I added allergies and chronic infections to what may contribute to depression as an inflammatory model, but then looked at other things that we can do to decrease inflammation. And I just picked a few. There are many, many others that we can talk about, but magnesium, the essential fatty acids, lithium, OPC, these a class of resveratrol, and these polyphenols that are in grapes and blueberries, and we'll talk about, and curcumin. Low-fats diet don't work. I eat fish every day and my butt still drags on the ground. Well, we've tried fat, no skim, light, anything else you can think of diet. It's done very little to our obesity epidemic. And what I hope you can appreciate in the work that we've been doing and many others is that the lack of fat, both cholesterol, saturated fats, monosaturated fats, and essential fatty acids have probably contributed to our increasing in neuropsychiatric illness. The omega-3 deficiencies gets talked about a lot, and I think what I'll share with you is perhaps talked about too much, where we're neglecting some of the anti-inflammatory omega-6 fatty acids that aren't addressed. And there's clearly research that's demonstrated over the last 10 years that the levels of omega-3 fatty acids directly influence the magnitude of the inflammatory response, particularly to distress and depression. So we're all insulted by these environmental factors, and that's what I talked about when I said, really, what are the genetics to depression? Well, it's a liability, but what triggers it? And it's clearly these environmental factors, and our levels of nutrients, particularly omega-3s, can be one of the factors that can influence how we respond, and do we can have a chronic inflammatory reaction or not. To restore the essential fatty acids, it takes 10 or 12 weeks, so it's not an immediate effect. And sometimes our patients aren't as patient as we would like. Original study in 1999 by Andy Stoll, where he used high-dose EPA, and it, I believe, has kind of created lots of confusion in the field, and people are taking high-dose EPA to treat psychiatric illnesses. And I don't think the literature kind of supports that, and we'll talk more about it, but the punchline is I believe DHEA is just as anti-inflammatory, and we have found, as we do fatty acid testing, that patients on this kind of high-dose EPA program for long periods of time creates a deficiency in the omega-6s, the GLA, and also sometimes creates a deficiency in the DHEA. So I don't recommend high-dose EPA, but it has been kind of brainwashed into the psychiatric community. I am a very firm believer in the essential fatty acids in the treatment of psychiatric illness. We try to do as much testing as we can. These are some newer studies just came out this year looking at the what we call meta-analysis for bipolar disorder. Here it was shown the omega-3s were helpful for the depressed phase, not for the manic phase. And then for the ADHD world, I wanted to throw this just because it clearly addressed the omega-3s by itself has not been shown to be particularly helpful, but the omega-3s and the essential omega-6s, GLA, did help in the ADHD kids. So this is a nice study looking at the omega-3s and inflammation. It was done on medical students. It was a brief study, but they were given a relatively low dose of the omega-3s, EPA and DHA. And what we see is in the short term, the students who received the omega-3s had less of these inflammatory markers. They also had reduced anxiety. The testing was done, blood samples were taken before stress periods, which was the exam, the day before the exam, and then lower stress periods. And those individuals that got the omega-3s, they had less of this immune response and less anxiety. In this brief study, there was really no difference in the depressive symptoms. Again, we were looking at changes that were immediate in the blood before an exam or those were less stressful. But a really nice example of how the omega-3s can dampen this inflammatory response. And again, if we think of a chronic state, and some of us do have memories of medical school, that it's not just exam one, but over years and years of chronic stress and how that affects our inflammatory response. It's hard to talk about the omega-3s without some of the newer studies that many people have heard me talk about, but there's been a profound association between low levels of omega-3 and suicide. This is the recent study this year looking at veterans and lower levels of DHA in the blood, higher rate of suicide with our returning veterans. I've been talking about this slide over the past year. Many have seen it, but again, a very powerful example of how omega-3s can affect neuropsychiatric symptoms. This was a study where they only gave 1.2 grams, again about a 2-to-1 ratio of EPA to DHA for approximately 12 weeks. So 3 months of fish oil supplementation decreased the onset of psychosis in this very high-risk adolescent young adult group. 5% those that took the omega-3 fatty acids versus 28% in the placebo group. Again, a simple fish oil pill decreased and delayed the onset of psychosis by a dramatic amount. This was published in a reputable academic journal, Archives of General Psychiatry. Didn't get on Newsweek or Time, didn't get a lot of press because it was a simple intervention that made a tremendous difference in these kids on developing psychotic illness. This is a patient that we've seen a number of months ago who had to leave college because she was developing parapsychosis. And if you see levels of all the omega-3s as well as low levels of the essential omega-6, so linoleic and gamma-linolenic acid. As her fish oil and GLA's levels were treated, her levels of her symptoms improved dramatically. This is a family that did not want medications initially, and levels of essential fatty acids improved her symptoms. Why are fats so critical for the brain? Well, the brain is working 24 hours, and 60% of the dry weight of the brain is fat. Again, it's not just the omega-3 fatty acids. Here you see a schematic of the membrane, and those yellow molecules in the middle are cholesterol. So please understand the relationship between low cholesterol and depression and suicide. And we've talked about this in the past, and there are webinars to look at, and lots of information in the book on depression and low cholesterol. If the brain is mostly made up of fat, then gaining weight in college help you get smarter. Again, everybody has a difference of opinion of what essential fatty acids to take and how much. I just want to make sure that everyone understands. I think the high-dose EPA is not anti-inflammatory to the extent that we need. I use DHA alone. Most of the time, DHA and EPA together in a closer to 1-to-1 or 2-to-1 ratio. When we talk about modulating inflammation, what vitamin has to come to our mind first? Vitamin D. We read about it, we hear about it, it's in the lay press, it got in Newsweek and Time, so it's okay for us to talk about, but there is not a single nutrient or hormone that is more directly related to immune function. And why vitamin D I think is so important, one, because so many of the country is deficient, but it is required for optimal immune function. There's a missing word there, immune function. So it regulates many, many genes. There's receptors throughout the brain, and what we've been able to show is vitamin D actually can help in a hypoimmune situation as well in a hyperimmune situation, chronic inflammatory illnesses like MS and rheumatoid arthritis. And vitamin D is associated, vitamin D deficiency, with increased markers of inflammation. With an inflammatory illness, be it depression or neuropsychiatric illnesses, I would aggressively get vitamin D levels up to levels much higher than I would with someone without symptoms. Sometimes 75 to 100 nanograms would be the dosages we would look at to try to help modulate this hyperimmune situation. Another example of a critical mineral that, if deficient, causes inflammation but can be used as an anti-inflammatory agent is magnesium. Magnesium, as you know, is depleted under stress as cortisol levels go up, which means our immune system is starting to get triggered. Cortisol causes the depletion of magnesium. Magnesium is hard to test for because the majority of the magnesium is in our bones and in our cells, so it's hard to do a serum level. It's hard to understand what those blood levels mean. We do look at hair levels as well as red blood cell markers, and there are markers on some of our functional tests, the organic acid and the amino acid, that helps us understand magnesium levels. But clearly, low levels of magnesium is both associated with stress as well as inflammation of the brain. There's research looking actually at head injuries and inflammation using magnesium, high-dose magnesium, decreasing inflammation in the CNS. The next thing I just want to talk about is briefly lithium. I believe lithium is a critical trace mineral that needs to get better understood by our medical profession. As psychiatrists, we used to use very high dosages to treat bipolar illness, and it's dramatic how good it was, but the toxic side effects very, very hard. But my interest in lithium goes back hundreds of years when we used small doses of lithium in our sodas. These were initially done to help prevent hangovers. And lithium was in 7-Up for many years, I believe up until 1950. Lithium citrate was added to our sodas. And I'm not sure that this was such a bad idea. Here's our traditional study showing how powerful medication is. Lithium decreasing rates of suicide dramatically in our pharmacological dosages. But when we looked at lithium in our water supply, this was 3 different studies looking at Texas and in Austria. This is over a course of 20 years. The overall suicide rate and mortality rate is inversely associated with low levels of lithium in the drinking water. And I believe lithium is one of the most important protective nutrients we have in brain function. And guess what recent literature has demonstrated? It demonstrates the effect might be as an anti-inflammatory agent. And what this research has demonstrated is that lithium reduces brain inflammation by adjusting a metabolite of the essential fatty acid DHEA. I'm going to skip the next slide, be happy to send you. This is the more complicated research looking at these inflammatory markers and how lithium caused the decrease in inflammation in the brain. If you want this article, I'll be happy to show you. So our colleagues are looking at lithium as a protective agent for mental illness, Alzheimer's. But here's a cover of a Discover magazine I picked up on a plane a year ago. But guess why nobody is going to continue the research? There's really no profit in lithium, which is a trace mineral, but it's really important that we understand. So, to summarize a little bit is trying to share with you how depression as a model for chronic inflammation. And depression is clearly aggravated by cytokines, and I hope I presented some of that information tonight. And there are many, many ways that our body produces inflammatory markers called cytokines. Depression is influenced by hormones and clearly by neurotransmitters. And the focus of the work that we do, the Zebra approach, the depression book, is these chronic nutritional deficiencies really play havoc with both hormones, neurotransmitters, cytokines that ultimately lead to depression. So if we target our therapeutic interventions to the biochemical imbalance, we're going to have better outcomes. And that's why the biomedical testing is so critical, because we really don't know what is contributing to the inflammation. Is it food allergy? Is it elevation of Clostridia marcus? Is it a hormonal deficiency? Is it celiac disease, a gluten intolerance? The hosts of hundreds of different potential biological causes of inflammation and depression need to get understood. And that's why we're trying to treat the fire, not the smoke. Trying to get at the underlying cause. And 10 patients walking into my office with depressed mood, there could be 10 different causes. And the testing has been critical in my practice to help us sort that out. So mental illness can be seen as a reflection of multiple errors in physiology. I don't mean to imply that there's just one thing contributing to the depression, a food allergy or a gluten intolerance. There could be a number of allergy factors. But the critical piece that is optimistic in our work and keeps me going is that if we find the causes, then we begin to understand cures. And we can talk about words that my colleagues don't use, which is recovery, which is remission, which means you don't have to struggle with this chronic relapsing illness. But the nutrition information that we're giving is sometimes confusing. It's easy to snack healthy at work. I get vitamin C from coffee, vitamin D from donuts, and vitamin B from bagels. So I use the